So my name's Brendan Fowkes, and I have a really fun job. My job is to work with healthcare organizations around the world every day and try to use technology to solve business problems. It's really fun. It really is. I get to do fun stuff. And I like to travel, so that helps. So when we think about this, and I was thinking about stats and technology and what we could talk about in preventative medicine and how we think one study says you could save $700 billion here in the United States of the $4 trillion that's spent with better preventative medicine, and I could go through all these stats. I said, you know what? I have a better idea. Let's talk about a story about how we can use these modern technologies today, an as is and a to be. Because I want people to be inspired of what they could do with these technologies as we look at the global challenges around the world. And as I talk to people around the world, it does come back to four things. Can we improve outcomes? Can we reduce costs? Can we provide better access? And can we provide a better experience, especially for caregivers? That was a great burnout story, by the way, Dr. Nolan, about using TM to help with the clinicians, because we have a burnout problem with our clinical members. So how we're going to get there. And I was speaking last week. I was at the Duke Health AI conference last week on the other coast. And the chief medical officer, Rick, was up presenting. And to think about improvement, as he said, we have a $6 billion health system at Duke. $2 billion of that is waste. Can you help me find that? He goes, I can't give you any money to find it. You got to find it and we'll recuperate the money because there's no extra money around. So if we think about some of that waste, so we're going to talk about three characters. So Mrs. Ramirez, late 60s, early 70s, widow, over, and we'll put her in Oakland. Kids didn't move far away, but with California traffic, they can be as much as 2 hours away from 10 miles. So she lives alone, widow, type 2 diabetic, hypertensive. Meds are great, doesn't exercise a lot. She lives by herself, doesn't get out very much. Dr. Gutierrez, primary care doc, busy, 2,000 patient panel, all kinds of stuff going on. I got 15 minutes per patient. I got to take care of my patients, but I got to do a million things. I'm charting at night after I put my kids to bed. And then Mary, the diabetes coordinator at Blue Shield of California, since we're in California. Same thing, massive panel, just tons of data in front of her, trying to help these people with diabetes take better care of themselves. So Mrs. Ramirez has her annual visit coming up. She goes and gets her bloods drawn, all that other stuff. They're not great, they're not horrible. Doesn't set off really any flags. Mary sees the results, says, yeah, we sent her a flyer. She can, she should probably exercise more and use her gym membership, that benefit that she has. She goes into her appointment. She's a little nervous because people have white coat syndrome. My mother's a nurse. She still has white coat syndrome, even though she worked with doctors her whole career. She admits it, her blood pressure goes up all the time. So it's one of those things. So she goes in, she's a little nervous. Dr. Gutierrez comes running in late, takes 1 second, late from her last appointment to read, runs in and starts asking her questions. But she's over here, playing with the medical record. And click, 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 click. Click, 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 click. There's not an experience, there's not an interaction. She asks questions. Mrs. Ramirez leaves out the fact that she's having dizzy spells sometimes, which means her sugars are all over the place. Because it wasn't an interaction, it was a lot of this and that and this and that. And away she goes, hey, you should really exercise, get out more. Okay. Mrs. Ramirez goes home, they don't change her meds, nothing changes. Eventually, Dr. Gutierrez gets around to actually finishing her chart at 8:30 at night while trying to help her kids do their math homework at the same time. A couple weeks later, Mrs. Ramirez has a fainting spell, falls, breaks her hip, ends up in the emergency room. Thankfully, she's had her phone on her so she could call and get help. Catastrophic mess. Happens every day. It's awful. It's a real scenario. It's sad. Where can we use technology to make this better? We're not going to diagnose anything, because then you got to go through FDA 10K compliance. That's a pain. We're not doing that. That takes years. Where can we just use these technologies to empower these people to take better care? So let's back up. Same scenario. Let's just change the paradigm a little bit now. So all of a sudden, she goes and gets her meds. She goes and gets her labs done. And like I said, they're not great, they're not bad. It all gets sent over, it gets sent to Dr. Gutierrez, ends up at Blue Shield. Blue Shield actually has this comprehensive program where they've taken not just your clinical data, financial data, administrative data, they have block level data about social demographics, access to food, access to transportation, propensity to not fill your meds, unstructured information. It's all pulled together, and all of a sudden, Mrs. Ramirez shows up on Mary's likelihood, 72.6% likelihood she's going to have some sort of adverse event in the next 3 months. And by the way, this is actually in production at Blue of California for diabetes already. Now, once again, okay, what does she actually have for healthcare? Now the artificial intelligence serves Mary. Hey, by the way, she's eligible to go to the Y, which is 2 bus stops away, even though she doesn't drive. 2 bus stops. Piece of cake, right? Go reach out and tell her that. So when she reaches out and tells her, hey, listen, you should really do this. The Y is 2 blocks away. She's like, okay. Not everybody trusts their health plan here in America because it is a trust economy. Most trusted person in healthcare, still your pharmacist. So she goes, okay. Now, wait a minute. That information is now served up to Dr. Gutierrez. So same scenario. She shows up for an appointment. At check-in, they say, hey, by the way, we'd like you to sign a consent form because we're going to use this technology that includes artificial intelligence to listen to your conversation with your primary care doc, because in California, you guys are leading the way. You passed a law the other day about AI and patient privacy and patient communications. Thank you for being out front as a state on what needs to happen around patient transparency and how we use data and how AI is regulated. Trends go from west to east usually. Hopefully the rest of the country starts to follow suit. Out of character. So she consents to say, okay, that sounds okay, all right. So now she's in a room. Now comes Dr. Gutierrez. Now think about this. Dr. Gutierrez is given a summary of all of that history, including the score from the health plan and the gym membership information and everything presented to her, so that 1 or 2 minutes she has before the appointment, she has a real understanding. Okay, I remember this patient. Let's go in and talk about her health and wellness. Let's get her to adopt that gym membership at the Y. So now she walks in with a goal. And they walk in, and they sit down and they have a conversation. There's no this. And they have it in their native language, first language in Spanish. And they talk to each other in Spanish about how you could be better, how you could feel better, how you can get out, take better care of yourself. So in that 14 minutes now of the 15-minute visit, Mrs. Ramirez agrees, I'm going to go to chair yoga at the Y. By the way, my mother does chair yoga now. She loves it. She's 78. So, but it's a social thing. Loneliness is as bad as smoking, they say. Now she's out. So she's going to agree to sign up for the Y and go do chair yoga, which, by the way, I had built in my scenario. So she agrees to go. Now, with that 1 minute extra, the doctor turns and the documentation's there for her to verify. She reads it, she makes a couple of edits, and in 1 minute, her charting is complete while it's fresh in her mind. She's not charting at home. Mrs. Ramirez goes home, she joins the gym, she goes to chair yoga, and she sees a woman that her and her husband, the couples, they used to go to dinner together all the time before her husband passed. Now she's out, she's social. There is no fainting event. What did we do there? We just made it easier for clinicians to be clinicians. So when we're thinking about this information, we're thinking about the technology here, the important thing to think about is what do we do to change an outcome? Who's going to do something differently if we empower them with this type of technology? And it's those fun scenarios, those fun stories, but there's a risk involved because everyone's got great ideas and we're not going to lose capture of this moment in time with the technology and the buzz we have. But the key is to make sure that when we have a good idea, we don't do something just to prove it works. What are we going to do differently? There's a great scenario from last week about this amazing predictive model they built in the emergency department at Duke. And the guy was up there, and we did all this work, and we did 97% accuracy of who's going to be admitted, who's going to be discharged, who in the middle still is yellow. They built all these dashboards, they studied the models, they had it published. It was great. And the ED doc goes, you know what I did differently with that information? Nothing. It did not change the practice of medicine in the emergency room at all whatsoever. We do the exact same thing we were going to do. All we did was prove that we were going to do what we were going to do anyways. So, and people, we're all guilty of these things. You want to prove, you got to publish, you got to do this, all this stuff. There's great ideas. What are you going to do with it? What are we going to do that's different? We looked at predicting one time medication adherent event, non-adherent. Who's going to be non-adherent on their medication program? What we found is middle-aged guys are the worst because we lose our keys. And I did remember to take my blood pressure meds this morning. I've told this story and been like, oh wait, I forgot to take my blood pressure meds. Because everyone in my, it's a genetic thing, everyone's got it. I was the last one of my siblings to go on blood pressure meds. But it's one of those things, but what are you gonna do if you predict that someone like me is gonna forget to take their meds? Well, let's study the features. If one of the features is economic uncertainty, financial insecurity, loss of job, that's a likelihood because the model's fully transparent, explainable, free of bias. So when a model gets pushed out, everyone understands why it said what it said. It doesn't make a decision, it empowers. And the thought is, one of the ones we did was actually, we're gonna just automate a 3-month supply order on us, and a care manager is gonna be triggered to call them to say, we're shipping you a 3-month supply of your medications for free. Here's how you need to remember to take them. We automated something. It was a different behavior to drive a different outcome. Not just, okay, now we know who's going to be non-adherent. Because there was another great study done 10, 11 years ago predicting the onset of CHF before it actually happens. That's great. We did this and that, and it was published. It was in Forbes. There was case studies done, press releases. We didn't do anything with it. Because the organization wasn't staffed to know what to do. Okay, now we have 1,100 patients in our 60,000 patient panel. What are we gonna do? Send them a letter? Hey, you should come in because you might have a heart attack soon? Some sort of congestive heart event? That's not good patient experience. Like, they didn't know what to do with it. So I think my advice is we come up with these good ideas, and as we look to pull the knowledge of all medicines together, what are we going to do differently? What do you want to do differently? What do you want that outcome to be? Reducing burnout, some of the TM stuff. I spend a lot of time with clinical teams. We call it intelligent workflows. How do we alleviate the burden in day-to-day life for clinicians of just stuff they don't need to be doing? You know, it was when Rick, the chief medical officer at Duke, was talking last week about all that waste. He just showed a slide of how they just cleaned the supply closet. That's it. Little lean Six Sigma modeling of what the supply closet should look like versus what it looks like in my son's room. My 23-year-old's home after college work. He has a job, but his room is still a disaster like he's 12. So we just close the door when he leaves for work every day. But that sort of efficiency, it doesn't have to always be some big giant model. And the other thing to think about is, as we think about a great idea and what we want to do and how we want to do it, how are we going to do it with a level of social responsibility? Every time you ask ChatGPT a question, it drinks a pint of water or a half gallon of water. We do not need to turn on a nuclear reactor in order to do these things. Warm the oceans more and create another catastrophic event in Florida. One of my coworkers' house, gone. Got battered the first hurricane, a week later, she's home. Single mom, teenage kid, doesn't have a house now. Like, you guys see this stuff in California, you guys, horrible weather events. We need to have a level of social responsibility along with a planned outcome that's gonna make somebody's life better. It's a great time, it's a fun time, and what other thing is great here that I think is good, I always remind people this, and actually I saw it, my wife watched it on repeat on Hulu, and she's fantastic, let's be honest. Is there a better interview? She's so good. And she had Scott, one of the co-founders of ChatGPT, And she called him on it. She's like, I bet you don't have people that look like me developing your software. And he was like, well, we're trying to hire. She's like, what are you doing about it? As you're thinking about a use case, as you're thinking about an example, the people you want to touch need to be represented in the project. You can't just have a bunch of super brilliant IT guys in the back room cooking something up without representing the people that they are going to work with. Especially if you're going to do something where you might translate from one language to another, because not all words translate the same way. Like you're working with a health plan. I'm a member of Anthem. Member translates sometimes into slang in other languages. It doesn't come out the same way exactly. I wouldn't know that if we didn't have an Hispanic member of the team involved. So there can be funny ones like that, but you got to think about the people you want to touch, and are those people represented as you design the project from day one? Here's my idea. Let's define what are the risks, what are the potential outcomes, who needs to be involved. You document all that. Then you let the smart people go to work. Then you get the people you're going to affect into the program, and then you make change. So it is one of those things. This is a really exciting time. There is no bad ideas. We just have to be responsible, ensure the data is free of bias, ensure that it's cross-representation on the team when we're building out the use case. So at the end of the day, we're going to automate something that makes somebody's life better. So I'm not a clinician. I just didn't like biology. So I've just been in this industry 30 years. I'm passionate about it. This program is amazing. When I was asked to come, and I did a little homework into what Touch a Life means, and obviously if you didn't catch it, I'm not from this coast, I'm from the other one. I was like, yes, I will fly out here on a Friday and do this, because what you're doing is great. And the way you describe the platform, people who want things to people who need things, that was so simple. It's just a really exciting time. Thank you very much for having me. Everyone have a great day.